Good afternoon. I'd like to welcome you all to this next workshop, which is real-world evidence in epidemiology in CF. I'd like to introduce myself. First of all, I'm not Dr. Ann Stevenson. Ironically, Dr. Stevenson is chairing an international registries working group at the same time that the epidemiology workshop is happening, which is obviously not the best timing. So I'm filling in, and my co-moderator is Dr. Christelle Bergeron. And so we have 5 speakers today, and as the workshop format, each speaker will have a chance to present, and then we can have questions afterwards. You have your app through the NACFC app to ask questions. And if people are not sort of connected in the room, it's a small enough room, we can do it informally if people wave their hands and ask questions just standing up in your seat. So I'll pass over.
Good afternoon. So our first speaker is Jennifer Taylor-Cousar. She's coming from the National Jewish Health, and she's going to talk about fetal impact of CFTR modulator use during assisted and natural reproduction and partner pregnancy in men with CF.
So thank you very much to the organizers and to you for inviting me here. It used to be that I'd be talking about pregnancy at every one of these sessions, but today I'm actually going to be talking about partner pregnancy for males who are choosing to stay on their modulators, or in some cases not. So this abstract is being presented on behalf of all of my co-authors that are listed here. Okay, so these are my disclosures, most of which are related to the fact that I'm the primary investigator on many of our studies. So, as you all are well aware, at this point, the majority of people are at least variant eligible for highly effective CFTR modulators. There are some, obviously, who are intolerant, and there are some who actually don't meet the qualifications based on their variants to participate in modulator use, but the majority of people are eligible. And so because there are so many people who are feeling better and, as you just heard in the plenary, likely living longer, this is projections which I think Liz Cromwell will be presenting a little bit later that will show some updated numbers for this. But as of 2016, if you look at the number of adults that were living with CF here in the US, it was around 18,000 at the end of 2016. Fast forward to 20 years from now, and we're looking at more like 30,000 adults, or maybe 40 or 50, Liz will tell us in a few minutes. But with people living longer and feeling better and really thinking about their futures, what they've been telling us is that we really need to be thinking and talking to them about their sexual and reproductive health. So just so that we're all on the same page, and as a reminder, males with CF are almost universally infertile because of congenital bilateral absence of the vas deferens, or CBAVD. Many males with CF are also missing part of their epididymis, but they do still have sperm. On the other hand, the majority of females with CF are actually fertile, and of course we think, based on the pregnancy numbers and some theoretical data, that they're actually more fertile on highly effective modulators. But again, most males with CF are infertile. We do know, though, that males with CF do still have ejaculate. It's just in smaller volume, and this is from data back in 1968 out of Boston Children's, where they actually looked at this question. Because some of the fluid actually comes from the prostate, it is actually still there, and in fact, we think that it may increase on CFTR modulators because there is actually CFTR in the prostate. And in fact, there were reports early on of males with CF who took CFTR modulators who experienced testicular pain that was self-limited in most cases. But we think that may be because of volume shifts. However, although they may have a larger ejaculate volume, and this is confusing to some males with CF, and so again, I think we need to be talking to them about this more. Although the volume is likely to be higher, that does not mean that they are now fertile. And in fact, the data from John Engelhardt's lab suggests that none of the males who are already born are going to be fertile after starting CFTR modulators because, again, it's congenital bilateral absence. So the only time that he was able to show in the ferret model that they actually were born with formed vas deferens is if the mother ferret was treated with ivacaftor throughout the entire pregnancy and that male fetus had 2 copies of G551D, a responsive mutation. So again, a male that's already born is, to my knowledge, not been shown to actually be fertile, and that's because they have bilateral absence of vas deferens that happens in utero. Nonetheless, males with CF are interested in pursuing fatherhood more and more because, again, they feel more hopeful about their futures. So the question that has come up in clinic is whether or not modulators impact fertility in males with CF. So they do look at the individual models. In animal models, they look at the individual modulators, and there wasn't any impact on fertility at normal human doses, nor was there any impact on chromosomal abnormalities. However, the average life cycle of the sperm is about 74 days. Furthermore, small molecules are expected to achieve a concentration in semen that's similar to that in plasma. So it's likely that 100% of the ejaculate is absorbed across the vaginal wall of their partner. So if they're taking a modulator, it's there in a similar concentration to plasma, and all of that's going to be absorbed. Now, again, in theory, that should be a small enough amount that it's not going to affect the unborn fetus, but we do not have a lot of data in people who have been taking modulators to verify that. So the bottom line is that if a male is planning to undergo assisted reproductive techniques where his sperm are going to be aspirated, combined with his partner's egg in vitro, and then reinserted, the only way to ensure that no modulator exposure happens is for that male to stop his modulator for 3 months and to use condoms during the entirety of his pregnancy. So why might a male not want to stop his modulator? Well, I think some of you are familiar with this data that Scott Donaldson published several years ago showing that 3 people in his care who abruptly stopped modulators had decline in their health, and unfortunately, in fact, 1 died. Also, data from the phase 2 study of Alex-Tez-Iva showed that trial participants in this one case series actually had decline after they had to stop the modulator in the phase 2 study. So 7 out of 10 had lung function decline and 5 had pulmonary exacerbations. And then furthermore, when we looked at this question retrospectively in females with CF who were considering whether or not they should stay on their modulators during pregnancy, 36% of them who stopped their modulators abruptly because of the pregnancy actually had decline, either pulmonary or had pancreatitis. So our hypothesis was that the use of CFTR modulators by males with CF during conception and partner pregnancy would not result in an increased miscarriage rate or teratogenicity based on the animal reproductive model data. So in a similar fashion to what we did with the retrospective surveys for people with CF who became pregnant, we asked caregivers across the world, mostly in the United States, United Kingdom, Australia, and Israel for this particular survey, and asked them to look back in the records and see if their males actually stopped their modulator or continued it during the ART process or, in a few cases, natural conception. So it was distributed in August of 2021, and then we sent a reminder in September of 2022, and the IRB actually determined that it was exempt because no identifying information was collected on any of the males. So our results, there were 42 partner pregnancies. Majority of those males used assisted reproduction. The average age was around 32. Their lung function was mild disease. They had a good BMI for males with CF at 24. The majority were actually homozygous for F508del. So looking at modulator use during conception and partner pregnancy, I've shown on the x-axis the different modulators, and so clearly the most commonly used modulator was Alex-Tez-Iva, although some people did actually transition during their partner's pregnancy. There was an average preconception CFTR modulator exposure of about 18 months, although there was a wide range based on availability of modulators across the world. There was one newly diagnosed male with CF who was diagnosed because he was infertile, who actually chose to initiate after his ART. There were 4 males who stopped their modulator, and one of whom had a pulmonary exacerbation when he stopped his modulator. Of the 27 males who actually reported whether or not they used condoms, all said they did not. So what we saw in terms of in utero and pregnancy complications and postpartum complications, so the miscarriage rate in the first trimester was 11.9%, which in the US is consistent with that seen in the general population. It's usually 10 to 15%. There were 2 women who had COVID, there were 2 breech. You can see that there was some overlap with some of these signs and symptoms. And there was 1 fetal loss of 1 of the twins. In terms of postpartum complications, assisted delivery occurred twice. There were 4 infants who had hypoxia and required NICU stay. 3 moms had postpartum hemorrhage. 2 had twins. There were no congenital anomalies reported in any of the infants, and none of the infants have CF. And importantly, I think the caregivers reported that they didn't deem any of the complications that you see listed here were related to the male's use of modulator during his partner's conception and pregnancy. So in conclusion, with the increased quality and quantity of life that's being afforded by CFTR modulators, more males with CF are considering fatherhood. Animal reproductive models actually demonstrate no genotoxicity or teratogenicity associated with CFTR modulators when tested individually, not in combination, at normal human doses. Okay, that wasn't good. Use of CFTR modulators during partner conception and or pregnancy has not resulted in a higher than expected miscarriage rate in partners, nor in any congenital anomalies. But in counseling males with CF regarding CFTR modulator use, if that male is really concerned or his partner is really concerned about the use of modulators and the potential exposure, because we don't have that much data, you really have to explain to them how long they have to be off, which is 3 months with use of condoms, and then also talk about the risk to their health if they stop. So with that, I'll say thanks to all the contributing centers, the support of the Asher Family Fund, and then for those of you who watched Plenary 2 online in 2020, those 2 actually talked about the fact that they now were considering a family because he was doing so well on CFTR modulators, and that is baby Leo. And I'll take any questions.
Thank you. I don't see any questions on the app. Are there any questions from the audience?
Maybe I can ask a question.
Sure.
So there's sort of the 2 points of potential exposure, one at the time of the sperm aspiration and the other at the time of the semen throughout the pregnancy. Mm-hmm. So the sperm aspiration is kind of a moment in time, and so it's like the time that the sperm was forming, it would have been exposed to CFTR modulators.
Yeah, unless they stopped at 3 months before that.
Unless they stopped it before
Right.
that. And so, but given that there haven't been any effects seen in animal studies on the sperm, one sort of compromise might be, instead of stopping for 3 months and having the risk, is just, minimizing exposure to semen during the pregnancy.
Right.
And so I think it sort of is quite important to sort of know what the risk is to the sperm development, because
Right.
that, and then you can sort of balance things maybe a little bit more.
Yeah, I agree. It's an area that's ripe for study, and I'm hoping that I can convince John Engelhardt that he should look at this in the ferrets. Any other questions? All right, thanks very much. Oh. So the question is, how many women with CF have given birth since it was approved? So based on the 2021 registry data, in the US, 675 women were pregnant. And we don't know how many stand there modulators because it's not, the data collection for medications is not the most consistent in the registry. But there's a whole session tomorrow at what time, Raksha, help me. It's a symposium that's on reproductive health, and mostly we'll be talking about pregnancy in females with CF on modulators and off. Yeah.
Thank you. Okay, so now we're welcoming our second speaker, Michael Sketchter, sorry, who's from the Children's Hospital of Richmond at Virginia, and he's going to talk about the impact of repeated non-treatment on long-term lung function.
Thank you. Do I have to tee up the slides, or how do I do this? Just, no, okay, I don't know. Should I just try to go through the,
To go to the end.
oh, okay.
Then you can select yours.
Right there, okay.
And then start.
Okay.
That's the first one on there, yeah.
Good. And, oh, I do this? Okay, good. So I want to thank the organizers for this talk, for inviting me, and want to point out that I'm speaking not just for myself, but Wayne Morgan, who really was the primary author on this, but couldn't make it to the meeting, and Josh Estrenga, Elizabeth Cromwell, D.B. Sanders, and Clement Wren all made contributions. So we'll be talking about the effect of repeated non-treatment of lung function decline events on long-term FEV1. And maybe I'll just use the computer to move things along.
The first line, if you forward it there, then the clicker should work now.
I think I'm just,
For the first one, and then the clicker should work.
okay. So I got to, and now, okay. So I have no specific disclosures in relation to this, this analysis. So first of all, I just want to point out that we've done a couple of studies, both using the epidemiologic study of cystic fibrosis, which goes back now about 20 years, and more recently analyses of the Cystic Fibrosis Foundation patient registry to look at antibiotic treatment of acute drops in lung function amongst patients. And clearly what we can see a few things from that. First of all, we see that antibiotic treatment of acute declines in FEV1 was associated with a greater likelihood of lung function recovery. Nonetheless, about a third of declines greater than 10% were not treated in the ESCF, which again is long ago, but 47% of declines of 5% or more were not treated in the CF registry more recently. So there's still clearly a significant number of these drops that are not being treated with antibiotics. The aim of this particular analysis was that while we've already looked at antibiotic treatment of individual acute declines, we were interested in looking at the impact of repeated untreated declines in patients who were followed longitudinally because, again, obviously CF is a chronic disease. So we're going to be looking at that. So our objective specifically was to evaluate the impact of repeated non-treatment in response to acute relative declines in FEV1 on long-term lung function decline, and specifically to evaluate whether repeated non-treatment is associated with likelihood of maintaining FEV1 within 95% of the initial baseline at the beginning of the study period. So we used the CF Foundation registry to look at people with CF between 6 and 18 years of age, so we're focused on children for this particular analysis. Although if they were 17 at the beginning, then we would follow them along even after they reach the age of 18. We excluded patients with a low baseline of 50% predicted or less. Again, in the pediatric population, that would be a relatively exceptional group. And we also specifically wanted to see people who had more than one decline, so at least 2 declines, and then again, trying to avoid the outliers, we limited to no more than 6 declines over this 3-year period of time. And then in order to be followed, they needed to have a minimum of 1 year of follow-up of PFTs. We excluded post-transplant PFTs and post-Trikafta PFTs, and again, I'll point out that This study was done in, or the analysis period is 2019, so there were very few patients who got Trikafta. So there's a few parameters that I want to just sort of lay out for you so you understand a little bit about how we did this, because this was kind of a complicated analysis that, frankly, we're still trying to work on and hammering at some of the fine points. So first of all, we defined a baseline measure, and we defined that measure as the highest PFT in the previous year from any specific PFT that was going to be evaluated. Or if the patient had an IV-treated exacerbation, then baseline is the highest PFT taken after that IV exacerbation start date. Now, that's a fairly aggressive definition of baseline that a lot of people would not necessarily agree with. And we are planning, I'll just tell you, we are planning on looking at a number of alternative definitions for what that baseline was, but for reasons that I won't get into here because it'll take too long, I actually use that sort of approach in my own clinical practice. And so the point is, though, that because we're looking at baseline being defined as the best in the past year or since the last pulmonary exacerbation, then any one subject could have multiple baselines over the period of time of analysis. Declines were identified as a relative decline of 10% or more. So, for example, somebody with a baseline of 70% predicted would have a drop of 7% predicted in order for that to be a 10% decline. And then, as mentioned earlier, declines of, or maybe I didn't mention this, but if somebody had a really dramatic decline of 50% or more, again, that was also excluded from our analysis as being somewhat of an outlier. And then treatment was defined as antibiotics within 28 days of that decline. And again, we are working on using a number of different definitions of this, but for purposes of this analysis, we created a dichotomous variable in which it was any antibiotic, IV, oral, or new inhaled antibiotic, or no antibiotic. So just to give you a little bit of an idea about how this translates out, can you see my arrow here? No, you can't. Okay. So basically, just to give you an example of a hypothetical subject, so they may have started at the beginning, upper left-hand corner, with an FEV1 of 100% predicted, and then a few months later, they had a drop down to 90% predicted from that, and we would consider that to be what we'll call, for example, a treatment opportunity for whether that was going to be treated with an antibiotic or not. These two subsequent drops of 5% from that baseline were not really considered. And then another 10% drop would have been considered as defined here. Now, when we get to what's approximately July 2017 in my little timeline here, you see that that's been over a year since the baseline that was defined in June 2016. And so now we're looking at what's the best in the past year, which is at this point 95%. So this patient now has a new baseline of 95%. Subsequently, they had another drop, which was another treatment opportunity that led to a hospitalization. But at the return of that hospitalization, they may have only gotten back up to 90% predicted, which again we defined as their new baseline. Okay, so they had some subsequent small drops that we didn't really count, another actual tiny increase, which increased the baseline a little bit. And then we have our final FEV1 at the very end of about 89% predicted, which is then compared to the initial baseline that was defined for purposes of how well their FEV1 was preserved over the entire treatment period. So this is just, again, just to explain how we went about doing this. Other parameters that are worth talking about are exposure, and again, we also created for purposes of this analysis a dichotomous variable where patients got either, whether they got treated with an antibiotic, either less than 50% of the declines or greater than 50% of the declines. And we're going to be comparing those two groups. And as mentioned, our outcome is that we are using for purposes of this presentation is return to 95% of the initial baseline. And in order to, again, be included in this, they must have had PFTs within 180 days after the final decline. So going through the registry, we started off with 5,685 CF patients between 6 and 18 years of age with 2 to 6 relative declines of FEV1 of 10% or more. Again, 2,700 were excluded, many because we had less than a 1-year total. We needed to follow their PFTs or their period of decline over at least a year, and only about this many met that. A number of others didn't have follow-up PFTs. So we ended up with 2,959 patients who met inclusion criteria, of whom 1,069 patients had less than 50% of their declines treated with any antibiotic, and 1,890 patients had more than 50% of their declines treated with any antibiotics. Which, by the way, means that 36% of patients had less than 50% of their declines treated with antibiotics. So this gives you a little bit of a picture of the demographics of the patient population, and specifically comparing those who had more than or less than 50% of declines. Female sex, Caucasian race, and Hispanic ethnicity were not statistically different. Mutation class, you can see there is more of a tendency for those with class 4, 5, and other unknown class mutations to have less treatment. Patients who had private insurance were actually more likely to have less treatment. Those with state insurance or other were more likely. And then those with CFRD, interestingly enough, were more likely to be treated. Other characteristics, and we're going to be showing some figures on this as well, but just to point out that in general, baseline age was different across these two groups. Patients who were younger tended to get less treatment. Patients who had higher FEV1 tended to get less treatment. Patients with fewer declines tended to get less treatment. And then those with Pseudomonas and with MRSA actually tended to get a little bit more, tended to be more in the higher treatment group. So just to show this, the relationship between age and treatment, again, you can see most clearly that the 6-year-olds, and then to some extent 7, 8, and 9-year-olds were clearly those who were getting, who were in the lower treatment group, whereas those who were 12, 13, and so on above were more likely to be in the group that had more treatment. And then again, when you look at FEV1 at the time of the drop, you can again see that those who had lower FEV1s were more likely to be in the higher treatment group. So we then used a logistic regression model to evaluate the odds of FEV1 at the end of the observation period being within 95% of the initial baseline FEV1, with the exposure of interest being, again, this grouping of antibiotic treatment of FEV1 declines. And our logistic regression model included baseline age and FEV1, the number of declines over the decline period, infection status in relation to either Pseudomonas or MRSA, and demographic factors as noted here, including sex, race, Hispanic ethnicity, mutation class, and insurance status. And so the bottom line is that patients who had more than 50% of their declines treated were more likely to be within 95% of their baseline at the end of the treatment period with an odds ratio of 1.35. Interestingly, and I think this probably is explained at least in part by the fact that we still need to work on how exactly we're defining treatment. So in this model, in this multivariable model, even when you look at treatment frequency, the fact still remains that the patients with lower FEV1 were more likely to return to baseline. In other words, the ones with higher FEV1 were more likely to lose ground. And those patients who were 6 to 10 were actually more likely to stay within the baseline period, whereas those older kids were not. And again, patients who had fewer declines were more likely to stay within their baseline. At the bottom here, you can see a variety of other covariates in our model were not statistically significant. So in conclusion, a substantial proportion of pediatric people with CF with multiple FEV1 declines of greater than 10% are inconsistently treated with antibiotic therapy. Again, this just confirms what we've already been able to evaluate. More frequent treatment of these declines is associated with increased odds of maintaining FEV1 within 95% of baseline, accounting for key risk factors and independent of baseline FEV1. And again, we're still working a little bit on a number of other sensitivity analyses, including alternative definitions of baseline FEV1, comparing IV versus non-IV antibiotics for decline events, testing other exposure classifications, including declines of less than 10%. Our analysis of single acute declines suggested that treatment of declines of 5% made a difference in terms of return to baseline. Looking at absolute number of untreated declines and a number of other things. So thank you very much. Again, my co-authors here, and we'd also like to thank the CF Foundation and the patients who were listed in it. Thank you.
Thank you. Okay, so we have two questions from the app. The first one is how accurately are antibiotics recorded in the registry? And is it possible you missed some which could lead to misclassification and affect results?
So how accurately is what listed?
Antibiotics.
Oh, antibiotics, right. Right, absolutely. There's no question that there is some problem with listing of really all medications in the registry, including antibiotics. And so I think that, again, with all of our analyses using the CF registry, we have to acknowledge that our precision of exposures and outcomes is less than ideal. And oftentimes, our way of getting around that is talking about how non-differential misclassification tends to err towards the null hypothesis. So if anything, one might argue that if we had more accurate recording of all of these variables, we would see a greater treatment effect. But that's also assuming that the misclassification is non-differential, which is a big assumption.
Okay, and do you have any hypothesis or reasons for less treatment of younger, healthier, or fewer exacerbations?
Is there a reason? Is that the question?
What are the reasons?
Well, we can't really answer that based on the registry analysis. I think that this gets into the whole principle of quality improvement and how many times our intended treatments are not actually followed through on in real practice for a variety of reasons. There may be other more intentional reasons why they're not treated, but again, there's also a tendency to just think, well, somebody starts with 100 at 120 or 110% predicted. Well, if they lose 10%, no big deal. They're still better than my lung function. So there's a little bit of a tendency, I think, to discount drops in lung function in patients who are starting out high. And again, as has been shown by previous studies, the result is that oftentimes those patients who have higher baseline lung function are the ones who have the most rapid decline when they're followed up on. Okay.
So there's been a lot of data in the literature recently about particulate matter and how much that might be different on exacerbations and other airway diseases. So could you use those, for example, to look at whether that's a covariate that could impact in this group?
Well, we could, but I think that would provide a little bit more of an explanation for maybe why certain groups have more exacerbations. But if the point of what our analysis is to look at the antibiotic response to those exacerbations, it's probably not really directly relevant, unless you think that people are going to not treat because the air, they're having a bad pollution week or something. But, okay, well, again, but our focus really is on the antibiotic treatment, so I think that the idea of what are the underlying causes of exacerbations is a really interesting and important topic, but I'm not sure that it would have an impact on what we're looking at here.
Yeah, go ahead.
Well, again, I think that, what were you thinking? Is basically it, and again, to some extent, yeah. Well, I think that there may be some cases where a decision is made not to treat with antibiotics because, for example, the physician interprets the drop as being related to another diagnosis like asthma, or for that matter, allergic bronchopulmonary aspergillosis. Now, for this analysis, I don't think we looked at ABPA. There have been other analyses that I've done looking at non-treatment for pulmonary exacerbations, because we have a whole series of studies that have looked at this. And we have accounted for at least a documented diagnosis of ABPA in those analyses, and they don't really explain it. Asthma is a little bit of a different story. It's not really well documented in the registry, and there may be times when somebody just decided they're having acute bronchospasm. For that matter, it's possible that they may do post-bronchodilator FEV1, and that's also not necessarily recorded in the registry. So that may be, that as a general concept is one idea that, again, the physician recognizes the drop, but is considering other diagnoses. Another might be, well, we know that you haven't been doing any of your airway clearance for the last several weeks or months or whatever, and if you don't get started with that, we're going to have to do something, and so then they do that and they bring them back and see. So that's another possibility as well, which again is not really well recorded.
But non-adherence, which may be the reason why the physician doesn't treat with antibiotics, but non-adherence over time would likely be associated with not returning to baseline too. Right?
Right. But again, so that's true, but we don't have any good recording of that variable again. So, yeah.
Maybe one last question, and then I think we'll need to move on. Someone asked, how should results be clinically interpreted now that most patients are on ETI? Because you mentioned that you excluded patients after Trikafta initiation.
I don't want to extrapolate this to the post-ETI era. I think we just need to do the analysis again. I mean, I think that there's limited, the data that I'm aware of in relation to ETI is that ETIs clearly reduce the number of exacerbations, but they don't necessarily reduce the likelihood of return to baseline, or however you want to define successful treatment. So even on ETI, patients who have exacerbations still have some of the same sorts of situations. But again, I think that until we have a few years more of ETI treatment, will just be kind of speculative. But I do look forward to repeating these analyses in a couple of years.
All right, thank you.
Yeah, there's no stairs on that side, so that would be a mistake. So I'd like to introduce our third speaker, Dr. Kyle Bilton, who will be speaking about vaping and vaping exposure in children, adolescents, and young adults with cystic fibrosis, prevalence and outcomes. Dr. Bilton's from the University of Alabama.
Hey guys, I'd like to thank the selection committee, and this is a great opportunity, I think, to share my project with you guys regarding vaping in the CF population. I'm just a fellow, so I have no disclosures to discuss. So I think most of us know by now that vaping has become a very popular modality for the inhalation of nicotine and other combustibles. Over the last 10 years, we've seen a decline in the rate of cigarette smoking. However, over that same duration, we've seen a marked increase in vaping. Every year, the National Youth Tobacco Survey comes out, and in 2022, we saw that 14.1% of high school students and 3.3% of middle school students had endorsed vaping within the past 30 days. When we look at vaping in patients with chronic lung disease, we can turn to our asthma patients. It was shown that adolescents with asthma actually have a higher prevalence of vaping compared to their age-matched peers in the general population. And this is thought secondary to a perception that maybe vaping is a safer modality compared to cigarette smoking. But we know that vaping has many pathologic effects on the lung and the airway. These include a decrease in cell proliferation, increased airway inflammation, increased bacterial burden within the lungs, decreased macrophage and neutrophil function, as well as decreased ciliary clearance. And as you might imagine, several of these may have implications for our patients with CF. Exposure comes in many different forms, and that's true for both cigarette smoking and vaping. We mostly think about exposure as primary exposure, wherein the user inhales aerosol from the device themselves. In secondhand exposure, the aerosol can accumulate in the air and be inhaled by friends or families in the nearby area. And then in third-hand exposure, aerosol can stick to clothing and other surfaces and later be stirred into the air or ingested. And secondhand vape exposure has been associated with increased symptoms of bronchitis and shortness of breath in adolescents. Now, the effects of secondhand tobacco smoke exposure on CFTR has been well documented. It's been shown to have an inhibitory effect on the protein, which is at least partially induced by acrolein, which is a metabolite of nicotine combustion. This is also released with vaping nicotine. And in secondhand tobacco smoke exposure has been shown to be independently associated with decline in FEV1 in children with CF. In my own institution, Dr. Lin and her team demonstrated that vaporized e-liquid exposure is associated with a reduced chloride transport at the cell membrane. However, overall, there remains a dearth of evidence regarding the effects of primary vaping and vape exposure in our CF population. Which leads us to our research question. The first question was looking at the prevalence of primary vaping and vape exposure in our children, adolescents, and young adults served at our UAB program. And here we hypothesized that the prevalence of vaping in this group would be similar to that of their age-matched peers in the general population. Our second question looked at the association between primary vaping, vape exposure, and respiratory outcomes, including any hospitalization for pulmonary exacerbation and FEV1. And here we hypothesized that vape and vape exposure would be associated with increase in hospitalizations for pulmonary exacerbations and negatively associated with FEV1. Our study population include patients with CF between the newborn age and 26 years old who are receiving care at our UAB pediatric and adult clinics. Our outcome measures included any hospitalization for pulmonary exacerbation within the past 12 months, as well as the highest FEV1 for these patients within that same duration, and we drew these from our local CF registry. We also collected data via electronic surveys, which were administered on iPads separately to both patients who were 11 years and older, as well as the caregivers who accompanied our pediatric patients to the clinic. And then we went back to our local registry and drew many covariants. These include demographic information like age, sex, race, and ethnicity, socioeconomic factors like household income, insurance type, as well as parental education, CF modulator use, and any colonization with Pseudomonas or Burkholderia. We administered two separate surveys, one to the parents and one to the patients, but the first four questions for the surveys were similar, of course, with little change in verbology. The first question being, to your knowledge, has your child used any vaping products in the past year? In the past year, how often did your child use vaping products? Does anyone in your household use vaping products? And in the past year, how often was your child with somebody who used vaping products? These are all multiple choice questions. And then we asked two questions to the patients alone. And these included, in your entire life, have you ever used vaping products? And then how likely is it that you'll ever try vaping products? A total of 161 patients were represented by our study, and there were 211 surveys completed, including 50 dyads, wherein both the patient and the parent had answered the survey. We'll first look at the parent-only responses, and here we saw that a little less than 1/3 had endorsed that their child had any form of vape exposure. Comparing this to the patient-only responses, where over 2/3 had endorsed vape exposure. Then, interestingly, of the 50 parent-patient dyads who had answered, 10 of these 50 had discordant responses amongst each other. Our first table compares the characteristics of our exposure and our non-exposure group. I bold-faced and also added asterisks to the significant values here. The first of which we'll discuss is the age, wherein our exposure group had an average age of 15.4 years, as opposed to 9.4 years for our non-exposure group. The modulator use is also higher in our exposure group, which is likely associated with the age difference. Those with exposure were more likely to be female, and also were more likely to have concomitant tobacco smoke exposure, with half of those endorsing vape exposure also endorsing tobacco smoke exposure, as opposed to only 1/8 of the non-exposure group. And then the hospitalizations were also significantly different, which we'll discuss more shortly. So the overall prevalence of vape exposure within our study population was 31.1%. When we looked at primary vaping, it was 6.8% had endorsed this. We then narrowed our focus down to patients between the ages of 14 and 18 years of age, which represent our high school age group. We saw that this number increased to a vape exposure rate of 50% and 20% endorsing primary exposure in this group. Our second table here further breaks down exposure and primary vaping by age range. We see it redemonstrated that the age range between 14 and 18 years old had the peak exposure rate, or primary vaping rate rather, and that vape exposure had increased with increasing age. When we performed our analysis, we saw that each additional year of age increased the odds of vape exposure by 20%. I'd like to first focus on the graph on your left. This looks at the rate of hospitalizations for patients, and we compared the exposure and the non-exposure group. And then we performed a multivariate analysis and also with our covariates we discussed earlier to compare afterwards. So before adjusting for those covariates, we saw about an 8% higher rate of hospitalizations in our exposure group. And after comparing, we actually lost some of our power here because we were only able to include those patients who we had the demographic and socioeconomic data on, but that difference jumped up to about 18%. We then looked at any hospitalizations and the odds ratio for such, and after performing our multivariate analysis and screening for our covariants, we saw that it remained a 4.5 higher odds ratio for hospitalization for pulmonary exacerbation in our exposure group. We looked at FEV1. However, unfortunately, these did not meet, we didn't have the power to meet statistical significance here. But before adjusting for our covariants, we saw a 5.9% average higher FEV1 in our unexposed group compared to our exposure group. This fell to 2% after adjusting, especially when adjusting for age. We performed a power analysis, and when controlling for age, we needed a sample size of 5,760 patients, so only 5,600 left to go. To summarize, the prevalence of vaping exposure was 31.1% across our cumulative sample, and it increased by 20% for each additional year of age. The prevalence of primary vaping was 20% amongst our high school age patients with CF. And if we look back to the 2022 National Youth Tobacco Survey results in the general population, we saw this number was 14.1%. However, it is worth noting that the metrics were different. We asked within the past year, and they had asked within the past 30 days. And finally, when looking at pulmonary exacerbations, we observed a 4.5 higher odds ratio for a hospitalization for pulmonary exacerbation after comparing to the covariants that we had mentioned earlier. So there are several implications from our project here. The first of which is a need for increased education on the risk of vaping for our teenagers with CF. The second, it raises consideration for collection of vaping data in the National CFF Patient Registry. And it also establishes the base for the basic and translational research looking at the mechanism of how vaping might affect CFTR. There are many directions that we're heading in with our project, the first of which is forming a focus group with those patients who endorse vaping. We're looking to gain an understanding of what their understanding is of the risk factors and motivations for vaping. We're actually right now working on making vaping videos about educating them on the risk of vaping to be administered in our CF clinics. We want to continue our project into our adult clinics, and also are considering expanding to a multi-center study. And finally, we're going to work on devising a formal vaping cessation protocol for our hospital. I'd like to thank Dr. Gabriella Oates, who is my primary mentor and spoke earlier today on tobacco association with CFTR, and Dr. Elizabeth Baker for her help with our statistical analysis, Heather Hawthorne for regulatory support, Drs. Hector Gutierrez and Brian Garcia and their teams at the UABCF program, and then, of course, all the participants and their families. I'll open up for any questions.
Okay, so we have two kind of similar questions asking about the type of vaping, nicotine versus THC or other things. Do you think it can affect, the results?
Yeah, that's a great question. So also, it's worth noting that a lot of your THC vapes also contain nicotine as well. I do think it might have implications on the results, but we did not explore that in this project whatsoever. We tried to keep our survey very basic in order to increase additional participation. That's something we may be able to explore in the future, but knowing that acrolein, the combustible metabolite of nicotine, has effects on CFTR may mean that there is a difference between the two groups.
Another person asked about if you considered and asked about peer pressure.
We did not. That might be a good topic for our focus groups, though.
You'd mentioned you're expanding your study to the adult population?
Yes, so we're going to look at that age range between 18 to 26, just in hopes of increasing our capture of the percentage of people based on general population studies who might be vaping. Yes, so in that newborn to 14 age range, you're not going to capture nearly as much as you will probably from 14 to 26 years old. Hopefully.
Hopefully.
Right. Yeah.
And in your state, is marijuana legal? So we're from Canada, and marijuana is legal in Canada.
Yeah, I don't think it's legal to play the lotto in Alabama, so no. Yeah, Alabama has some stricter rules compared to the rest of the United States.
It's just that when we, in Canada, we always have to, because marijuana is legal, that sort of has, in many ways, surpassed vaping with respect to nicotine.
Oh, that's interesting. All right. Well, thank you, guys.
All right, our next speaker is Dr. Jonathan Zuckerman from Tufts University in Maine, who will be presenting a multi-center study of peripherally inserted central venous catheters, PICCs, predictors of difficult line insertion, malfunction, and soft tissue injury.
Thank you. Good afternoon, and I'm glad that I wasn't the first speaker because I barely got here for the beginning of the session from the plenary stampede. Well, thank you for coming to this presentation, and thank you for the invitation. How do I advance the slides? Just hit this? Or... Oh, okay. Okay. So I have no disclosures for this talk. People with CF often choose to have peripherally inserted central venous catheters, or PICCs, for administration of intravenous antibiotics. These venous lines are felt to provide ready access for a range of formulations, which sometimes can be irritating to blood vessel walls when delivered in the tight confines of peripheral veins. Deep venous thrombosis is the most frequent serious complication of PICCs and has been reported in up to 8% of people with CF. And though previous studies in this population have typically been small and single center and retrospective in design, we thought that it would be best to study this issue in a prospective manner in a multi-center trial. Now, most of you who care for patients with CF have your own memories of individuals who've experienced complications of PICCs over the years. And our inspiration for this study came in part from, to develop a formal study, came in part from Atul Gawande's book, Better. In a section describing how to become a positive deviant in the medical profession, he wrote a list, And item number 3 on the list was count some phenomena that you find interesting. You will learn something interesting. And so for the last 3 years, we've been counting and counting and counting with the generous support of the CF Foundation. And today we're going to present the results of our multi-center study. We did this in a mixed cohort of pediatric and adult patients at 10 centers from 2018 to 2021. And the primary outcome for the study included catheter-related venous thrombosis or occlusion of the catheter requiring removal. We also tracked a number of secondary outcomes, including catheter-related bloodstream infections and a number of composite secondary outcomes, which included predictors of difficult line placement, local soft tissue reactions, and catheter malfunction. So today's talk is going to focus primarily on our secondary outcomes, but I did want to lead, after this intro slide, I wanted to lead with some discussion of our primary outcomes, since some of the data changed from last year after we did some careful case review and some data cleaning. So here we see a flow map of our study protocol. We included adult and pediatric people with CF over age 6 who were undergoing placement of a PIC or midline at a hospital with an anticipated treatment course of 21 days or less. And we excluded individuals with implanted catheters and those on anticoagulation. Enrolled participants had relevant history, demographics, and clinical characteristics recorded, including their personal or family history of venous thrombosis, the number of prior PICs, age, sex, genotype, baseline lung function, nutritional status, diabetes status, and respiratory culture information, along with their Akron PES, which gave us an indication of how sick they were at the time of line placement. Detailed information was collected about the line placement, including the venous location selected, the venue where the line was placed, the technique for venous access, the type and size of catheter that was inserted, etc. Following line insertion, we photographed the insertion site and archived the images on a HIPAA-compliant cloud platform. We examined the insertion site and gathered information about line care and function and patient signs and symptoms about every 2 to 3 days. And we repeated photographs if we noted that there were signs of difficulty at the insertion site or if the patient reported symptoms. If the participant went home to receive part of their treatment in the outpatient setting, we contacted them by phone and conducted a similar evaluation, although we weren't able to visually inspect the site. The protocol was repeated until the line was removed. So this just gives some example of, on the left side, you can see a picture of one of the line insertions. And on the right side, it shows that we did regular measurement of line of arm circumference using a tape measure. So on this strobe diagram, we see the flow of eligible patients who are screened. We had 607 catheters that were evaluated in 429 subjects. And after we went through exclusions, we ended up with 375 catheters and 260 subjects. So I should mention that patients were allowed to come back for repeat visits, and we took that into account in our analysis. 2 major events happened that had profound effects on enrollment, and I probably don't need to tell the people in this crowd what affected our enrollment, but just for posterity, I will mention that the rollout of highly effective modulator therapy in 2019 affected our enrollment, as well as the COVID pandemic. And as we know, the number of exacerbations was cut down by about 80%, certainly for intravenous therapy. Okay, so this is a breakdown of a simplified version of what would be a table 1 for this project. We see that we had more adults than pediatric patients, but pretty good representation of pediatric patients, which is actually unusual for a study of this type. Most of the literature is really in the adult population. And then we have the breakdown by genotype. Our FEV1s are presented in the number of people with Pseudomonas and CFRD. The Akron-Pez score, the Akron-Pez is an indication of how ill the patient was on presentation, and we were interested in looking at inflammatory markers that might predict problems with these catheters. I'm not presenting that data today. Interestingly, although many of our patients, actually almost 80% of our patients had one line placed during the study period, many of them had a lifetime history of many catheters. You can see that there's one individual who had over 30 lines and came in 3 times during our study. And this is broken down by adults in the white bars and pediatric patients in the gray bars. We thought this would be an interesting way of presenting some of our data. This is a kind of a 10,000-foot view of all the catheters that were placed. So all 375 catheters are represented on this diagram. It's a temporal event sequence diagram that shows our primary outcomes. And the take-home message on this slide is that the event-free days are shown in light blue. And you can see the vast majority of these catheters had no problems. The symbols on the right show for the primary outcome, we were looking at deep venous thrombosis. We actually did not do ultrasound on all the patients as part of the protocol. We used something called the constant score, and the constant score looks at several signs and symptoms, the size of the arm, whether the patient has pain, whether there's swelling, even if it's not measured, the patient has a sense of swelling. And we also take into account whether there's an alternative diagnosis that best explains the symptoms. So for our study definition, a constant score of 2 is used to define DVT or superficial venous thrombosis. Now, in clinical practice, most of us would get an ultrasound of the patient's quite symptomatic. So when that was done, we actually did record the information, and on this diagram, we do indicate whether an ultrasound documented or confirmed the presence of venous thrombosis. Now, if we look at this in a little bit more detail, we can, all those symbols that were on the chart were really hard to see amongst this sea of light blue. But if we break out those individual cases, we can see on the top are the ones where the patients had venous thrombosis. The blue bars, I don't think this has a laser pointer, right? Does it? Oh, no, it doesn't. Just go back. Let's see if I can go back one slide here. Can I go back or just forward? Let me just try going. Here we go. Just see if that works. There we go. Okay. So the dark blue is showing the inpatient treatment, and the light blue, the light green color is showing outpatient treatment. You can see the time when these events occurred and what type of thrombotic event was occurred, whether it was ultrasound documented or not. And down below, as part of our primary outcome, we also included catheters that were occluded and became unusable. So if that required the line to be removed early, then that also met our primary outcome definition. So those are shown at the bottom of the slide here. So overall, our incidence of the primary outcome was 3.11 events per 1,000 catheter days, which is actually much lower than what has been published in the literature previously. A study by Mermis et al. Reported a prevalence of about 6.5 events per 1,000 catheter days. So one question you might have is, why the reduction? What's going on here? Well, we did look at patterns of line care in our study, and we found that there was wide variation in the frequency of prophylactic anticoagulation, use of these catheters for blood draws, and flushes with heparin. So each of these dots is showing an individual center within our study group. So we had 10 centers, and you can see that, for instance, for prophylactic anticoagulation, there's one center where in the adult population, 100% of the patients get prophylactic anticoagulation, and lesser degree in children. So there's wide variation in practice, but we notice that there's still a less frequent rate of our primary outcome. And one of the things that we learned from this study, looking back and comparing our practices to previous studies, is that many more of our patients had single lumen, smaller catheters, 4.5 French or less. So in the Murmah study and in other studies around that time, about 25% of the catheters were greater than 4 French. And in our study, less than 10% of the lines were that size. So we wanted to look at our data from a different angle and see if there were any other clinically relevant complications outside of our primary outcome that we might predict based on patient characteristics and line management practices. And one of the tools that we use is a validated tool of soft tissue and skin inflammation called the VIP score. It's the Visual Infusion Phlebitis score. It's been validated and goes from 0 to 5, and you can see just by the color which one is the worst one to have, right? So being a 5 is somebody who's probably going to want that line out quickly. And this gives you an example of one line where we took a picture at the beginning and the end of the treatment, and it had a VIP score of 0, which was quite common in our study. No problems there. This is a patient where they had a very painful area at the site of the line insertion, had a VIP score of 2, and that line actually had to be removed early. So when we look at these predictors of secondary outcomes, we actually divided things into 3 main buckets. One bucket would be, was the line difficult to put in? The second bucket is, was there difficulty with skin irritation or soft tissue irritation? And the third is, did the catheter malfunction? And within these 3 broad buckets, if we combine them all together, you can see that about 40% of lines had something go wrong with them. And the next question is, well, how bad is that? We can see that, for instance, under soft tissue and skin reactions, we had about 25% of the lines had some sort of soft tissue or skin reaction, but you only needed to take the line out in less than 5% overall, 5.5% in adults and less than 1% in children. Let's look at this in a little bit more detail. So we did some modeling, and we took into account for local skin reactions and for catheter malfunction, we took into account how long the catheter was in, since you had a period of exposure for these events. For difficult placement, obviously there's only one opportunity to put the line in, so we didn't look at, we didn't use time of line placement or time of treatment as a factor there. But for all 3 categories, we did take into account multiple lines placed in the same patient. So we accounted for that. So how do we read these forest plots? I think most of the people in the room know how to read these, but I was taught by one of my mentors, don't assume anything. So let's walk through the slide. The vertical dotted line is showing an odds ratio of 1. So to the right of this line is going to be an increased odds for whatever the variable is having an effect on the outcome. If you're on that dotted line, then there's no association between the predictor and the outcome. So as an example, if we take the center panel here looking at local skin reactions, and we look at catheter size, we can see that there's an odds ratio here of over 2 for there to be a local skin reaction compared to the referent, which would be a 4 French catheter. In children, you can see that using a larger catheter, 4.5 French or larger, has an odds ratio of, if I'm looking at this correctly, it looks like it's over 4 compared to the referent value, which would be 3 French. Now, we should recognize that there's a caveat to our analysis here, that our study was not powered to look at these composite secondary outcomes, but we think that it's still important to see the data and consider, would this be something that would be relevant to your clinical practice? Would this be the way that you might make a decision about either putting in a 3 or 4 French catheter? And it's certainly worthy of further investigation. The areas on this plot that are open, you may see some gaps here, and we were deliberate in looking at our models, how stable the results were for the output from the models, and where it was unstable, we didn't report these values. I guess the last thing to point out on these plots for the uninitiated is that the circular symbols show the point estimates, and then the whiskers, some of these whiskers actually go off the upper bound of the plot, so they're indicated by the arrows. Okay, so this is a summary slide showing that for local reactions, we actually had a number of factors, including the side of the line placement, so right side, and you can speculate why this might be so. I'd be interested in hearing people's thoughts. We have our own thoughts, but since this is somewhat exploratory, I'm not going to give you my speculations unless asked. We can see that French size seems to be important, the number of lumens, and interestingly, for antibiotic impregnation, we found that there was an increased odds ratio for local skin reactions. We did not have enough events or observations to really make statements about difficult line placement or catheter malfunction. But those of us who work in the hospital know that patients who are difficult to get lines in, they get a history, and we usually take some different approach. We did not mandate how these lines were to go in, so many of the patients who had more difficult lines would go to interventional radiology for their placements, just kind of by history. So in conclusion, more than 60% of inserted catheters have uncomplicated courses, and this is good news. We identified a number of predictors for local skin reactions which warrant further study and confirmation. And despite the occurrence of these problems, in more than 95% of lines, we're able to maintain the line for the full course. So how this has affected our our practice pattern at our institution is that we're actually taking a lot more metaports out because we're feeling like, first of all, with ETI, patients are having fewer exacerbations, and also we're finding that even though we used to think that having 7 or 8 PICs was going to be a risk factor for lots of problems, we're finding that for many of these patients, they sail through and they do very well if we manage them carefully. So I'd like to thank our entire group of collaborators through our PIC-CF network. They're listed here. And I wanted to give special thanks to Alex Gifford, a co-PI on the study, along with Allie Hinton and Lee Lucas, who are the kind of the rocks of our data analysis core. And with that, I will take questions. Thank you.
I just have a question. Did you, at the end of this, sharing all these results with the investigators, was there any thought to sort of a protocol or recommendations that you would make based on this, about the size of the catheter and, and just because there's so much variability you showed with, anticoagulation versus heparin flush versus using the line for blood draws. So were there any sort of recommendations shared with the investigators?
With the investigators or with a larger CF community? So I think we have to be careful about our secondary outcomes aren't really, as I mentioned, we weren't powered for that. But I think individuals, clinicians can make the decision. I know that at our institution, we have one vendor. We don't really have a choice of which brand of catheter we picked, and we did track that in our study, but we do have a choice of what size catheter we would put in. So I think that the way we're planning to present our data is to show the secondary outcomes, but on the primary outcome, we really don't have any predictors of thrombotic events. We can only look back historically, and that's the way we're planning to present it, is that in the context of what we studied and what we know from the past, it looks like we're heading in the right direction, that people are moving towards smaller single lumen catheters in general practice, and that seems to be a good thing.
And the low risk of thrombotic events, the lines clotting, is sort of, there are risks for anticoagulating patients when they have PICCs in place, if they are for an exacerbation with hemoptysis. So it's, it may be encouraging to see a low rate, so that may change your practice in terms of potential risks created from more chance of hemoptysis.
That's true. And if I can reverse the tables for one moment, could I see a show of hands of how many institutions mandate against blood draws from your PICC for concern about central line associated line infections? So we saw no line infections in any of our patients, and it's actually a problem at our institution where the patients are told that they have to get a peripheral stick. And we're hoping to at least use this data to suggest that for patients who've decided that they want to have access, that they should be part of that decision making. So, yeah. So the question is, did we look at the venue of where the lines were placed, and also and by whom? Yes. So we didn't look at by whom, but we actually tracked the venue. So we looked at bedside placement versus a dedicated vascular access suite versus interventional radiology. So we looked at that. We also looked at tip confirmation, whether it was confirmed by chest x-ray or fluoroscopy. And in our forest plot, you can actually see that fluoroscopy was associated with an increased rate of soft tissue infection, and that you can speculate why that might be so. My speculation is that when people are going down for a more difficult line, they're probably sedated, and they might get a little bit more tissue injury during the study, unbeknownst to the operator. But that's just speculation, but we did track that. And there are institutional cultures around that, for sure.
Thank you very much. Our final speaker will be Dr. Elizabeth Cromwell from the USCF Foundation, who will be speaking about cystic fibrosis in the United States by 2040, a population landscape analysis.
Great. Well, thank you so much for having me. It's really a pleasure to be here and to present this work. I have no relationships to disclose. Let me just make sure I can advance the slides. Okay. There we go. Great. So I'm presenting on a simulation study that aims to characterize the CF population over the next 20 years. And really the purpose here is to focus on quantifying the potential of an expanding adult population, and it's really intended to inform planning. So I want to be really, really clear that this model does not predict individual patient outcomes. There is no point of care application for this work. In terms of specific objectives, what we're looking at is trying to estimate the number of people living with CF through the end of 2039, so at the start of 2040, and also predict the distribution of the future population by various characteristics, notably age, lung function status, whether they're going to be eligible for the currently approved highly effective modulator therapies, and we define kind of being prescribed as a user, understanding that that data in our registry has some limitations, and deaths and first transplants in this period of time. So I'm going to go through this figure kind of bit by bit to kind of explain how the model works. What we need to do to execute the analysis is define an initial cohort. And so let me see if I can, oops, sorry, there we go. So what we want to do, if we look at these 4 boxes here, you can think of these as 4 discrete groups of people that we need to enumerate. So the first being people who are prevalent participants in the registry as of 2020. These are people we know and we have data on. We also know that there are people who have yet to be diagnosed, and we know there are people who have yet or not consented to participate in the registry. They're living with CF, they should still factor into this analysis because they may join the registry, they may enter the care model at some point in the future. We also know there are people lost to follow-up, so they may not have participated in the registry in 2020, but they were in the registry in the past, and many of them are still living. We also need to forecast the future births from 2021 to 2039. These people, obviously, we don't know who they are yet because they have yet to happen, but they will factor into the time period of interest. So you can kind of think of every person that might belong to these 4 categories as a row, and we want to stack them all on top of one another and feed them through an individual level simulation. So what we need to do first is identify an initial state. So in 2020, what are their characteristics? What might they look like? And so we have to give everyone a value for various covariates of interest for 2020 or their birth year for those future births that will enter into the simulation later. So that's age, their sex, their race, their ethnicity, and whether or not they're eligible for a modulator. And this is using the FDA-approved status at the end of 2020. And right now we're classifying ivacaftor or ETI as highly effective modulator therapy. And then the user status is defined based on evidence of prescription in 2020. And then finally, we characterize FEV1 status as a categorical variable using the annualized data from 2020. So these are 4 categories of high, moderate, low, and severe, as you can see indicated below. So one thing we need to do is construct synthetic data. And so this really, we know people that have participated in the registry, we have data on them, but there are all these individuals, the lost to follow-ups, the late or not yet diagnosed individuals, the non-consents, the future births. These are not people that we have seen information on yet. So we have to create records for them. And so what we do is simulate these individuals to match the distribution of subject characteristics that we expect to see. And so what I've done in this little table is just to kind of simply illustrate that if, for example, in a given birth year, we had 3 hypothetical people that needed to be imputed into this analysis, we'll randomly assign them sex, male or female, and we'll distribute out the other characteristics based on what we see in the registry data. So it's making an assumption that the people that we know something about reflect the people we don't know something about, which is also a strong assumption, but one we can test. And we can allow that assumption to vary through various iterations of simulation. So finally, what we do is allow this population to kind of iterate over these different health states or these lung function states using different transition rates, which I'll talk about in the next slide. And basically what the model will do is predict where people will end by December 31st of 2039. They'll either be in one of these 4 lung function categories, they may have received a lung transplant, or they will be alive, or they will have died. So to define these transition rates, and this is sort of a little messy flow diagram, but what you can imagine is that if we look at the top box here, individuals are born and they kind of immediately enter into a high lung function state under the assumption that at birth lung function is high. And then eventually people can transition between high and moderate to low. And there's different probabilities that govern whether or not people move between these states. And those will be different for people who we classify as being a user of a highly effective modulator therapy. And they'll also be differential by age. So this transition rates were fit using a logistic regression model as a function of age and whether or not we classify them as being eligible and therefore, and potentially a user for highly effective modulators. I do note that in the model, there is a mechanism that as children who are born will age into eligibility, they will switch from non-user to user if they happen to be classified as eligible based on their CFTR variant. This approach is similar to the model that was employed by our colleagues in Canada, looking at the impact of introducing Trikafta into that population. And that's a package called MixSim, which is available in R. So some major assumptions that influence our results, I think that it's very important to characterize those. The future bursts that we model and that I'll show you in a couple slides are really challenging to predict. We don't know the future, obviously, but the one question is, will the incidence of CF just follow US fertility forecasts? And so in the iteration that I'm about to present, what we see is a stable incidence. I'm assuming that what we see in terms of the incidence of CF in 2019 based on the composition of births that were reported to the registry will kind of hold. And it's really the fertility trends in the general population that will drive whether or not births go up or down. And so if we do that, what we actually see is a much higher number of non-white, kind of minority population individuals being born with CF, upwards of 30% towards the final years of the simulation. The model does not directly account for the impact of non-pulmonary CF complications on survival that might be mediated outside of lung function. We make a very strong assumption that children below the age of 6 are assumed to have high lung function. That may be defensible in the future era where if children are able to initiate modulator therapy earlier and earlier ages, but we don't have lung function data in the registry to characterize that younger cohort at the moment. We also don't have an opportunity to really account for duration of being in a given state. Right now, we're sort of relying on age as a proxy to kind of govern that relationship. And finally, I'll just note that the mortality risk that we are trying to estimate, particularly for adults who are over the age of 40, that the people who are in our registry today, they may not be generalizable to those adults in the future, so 10 years, 20 years from now. And there's a lot to be seen. And I think what's most exciting about this analysis is, for me, is to do it again in about 2 or 3 years when we have more follow-up data available. So once the model runs itself, which takes a few hours, what we do is aggregate the results for summary. And again, I'm not interested in looking at any individual person in this data set because the purpose of this analysis is really to characterize what the population may look like. And so we can look at prevalence by year for these various characteristics, or we can report out the number of deaths that the model predicts, or the number of transplants. So this is how the kind of simulation kicks off. The 2020 initial lung function states, which you can see here. And again, this is that assumption that these younger children are all starting out with high lung function. And everyone in pink represents someone who is post-transplant, so they may have had these are not transplants that were necessarily done in 2020, but they're prevalent individuals living post-transplant. And so this next slide shows the distribution of lung function kind of at the end of 2039. And so what I want to highlight here is this is, again, just one single iteration. And so there's many possible versions of these results that we could interrogate, but this is looking at, if we assume sort of the 2019 CF incidence kind of holds, what happens when I just rely on US Census projections to predict outbursts. So it's fairly stable over time. And there are, by the way, people in the study born prior to 1960. It's just very difficult to visualize all the way, in the slide. So I've just sort of truncated the figure there. So looking at the age distribution of individuals with CF, we can see a sort of stable under 6 population through most of the years, sort of declining pediatric and growing adult population. So I want to just note that in this analysis, we're looking at about 62% of the population in 2020 being over the age of 18. That's different than what our registry reports because I'm including all those synthetic imputed people that we have not yet captured in the data, as well as our lost to follow-up population, some of whom may still be alive. And then we get close to about, definitely over 75% of the population is over the age of 18 in 2039, by the end of 2039. So just focusing on adults, because I think that's a particular area of focus for the CF Foundation in terms of understanding how the care model needs to adapt to this expanding population. You can look at the distribution here of lung function. Again, this high state is above 90% predicted. This would be 70 to 90. So overwhelmingly people, I think this is overall good news, but maybe it's conservative because this is data fit largely off of the ivacaftor experience. So looking forward to seeing what this might look like when we have more follow-up data from the ETI era. I will acknowledge that I think the post-transplant estimates might be too high. We had about 90 transplants reported to the registry in 2020, 54 in 2021. That's really great news. It's very hard to model. So I think that when we look at the historical data over a long time period, The model really wants to keep predicting sort of what's happened in the past. And so I'm really curious to see if those transplant trends continue into the future. These numbers will definitely change. I'll also acknowledge the same thing holds for deaths. So just in conclusion, there's really changing demographics in UF births that we will predict out using some of the assumptions I presented today. And I think those have implications for newborn screening programs. If we have more people with CF who would be identified as belonging to a minority population, we need to ensure that those newborn screening panels will detect them so they can enter into pediatric care. The adults will certainly comprise a higher proportion of the CF population with lung function, definitely over 70% predicted, but in the adult population, it's about 45% in this model that might be over 90% predicted, and in kids, it's about 80% who will be in that highest lung function category. And I just want to further acknowledge the challenging predictions related to transplant and the need to test various alternative assumptions in contrast with historical data. So I'd just like to acknowledge my colleagues at CFF who are listed here and thank the CF Foundation for use of registry data. And of course, all of the people who work really hard to enter this information. Without their contributions, this would not be possible. So thank you.
We have one question in the application. Someone's asking, did you incorporate higher fertility rates in adults with CF in the expected birth diagnosis rates in the model?
The question is, I'm assuming, pertaining to people with CF having children with CF. We don't explicitly account for that because I don't think that's going to be a major contributor to new incidence of CF because you still have to have, that person has to partner with another carrier, and they have a much higher probability of having a child with CF, but it's not a guaranteed 100%. So I don't see that contributing overall to there may be a few, but I don't think it would bias the results. Well, so I don't actually know from our registry data among women who report a pregnancy if they then have a child with CF. Yeah. Oh, I see. Yeah. You could certainly add that in, but I haven't looked at it. Yeah.
And another question about birth rate. Do you think the assumption that the birth rate will stay stable is what is the sort of evidence over time or trends that might suggest that it does stay stable or not?
So I don't know, I feel like I'm going to get into speculation a bit, but if we look at some of the work we've done with the Canadian registry, we are seeing declines in incidence, and that's a publication that was just accepted at JCF. I actually suspect, if I can go back here, if you look at the data that are reported to us, I fit this off of 2019. This little dip here is 2020, 2021 is still aligned here. It's entirely possible it may continue to decline. I can't comment on why, but what I would like to do is actually operationalize the simulation to allow that input to have a lot of variation so that we can characterize the uncertainty in those estimates. I think that's entirely plausible, but it's kind of hard for me to comment directly on the data. Yeah, I think you raise an interesting point. That there's so many factors. There's expanded prenatal testing for carrier status. People have a lot better access to even, I think 23andMe will test for a handful of these, CFTR variants. So I think that you have a lot of different points that may be influencing the incidence besides just the mix in the population. Yeah, so I think it's hard to predict.
Yes, go ahead.
Yes. I think that's a valid point. Yeah, I mean, this model doesn't really account for a cure in this time span. I think that the question remains, if you were to have this treatment available and to the broader population, do they require follow-up? What are the ongoing needs? I don't know if that's, to me, this is really about planning for the care model. So even if someone were to receive that therapy, do they still have to have follow-up? And does the CF accredited care model network need to support that? So, I think it's an interesting thing. You could put that in here to try and understand what the impact of that might be, but yeah.
And at what point would you look at the model again to get a better idea of your the transplant rate? Because that's sort of something that we're getting a hint that might be different, but...
Yeah, I would like 2 more years of data, personally. Because right now we have 2020, 2021. So if I have 2 more, I feel like with 4 years of follow-up, if it continued to stay low, it would give me some confidence that that was more of a trend than just sort of a blip.
It's pretty clear, like, we're going to need more adult clinics. Right?
I suppose so.
So you're planning for the foundation. They're already starting to work out, where are we going to put all these adults?
Right.
Any other questions? Okay. Thank you very much.
Thank you.